Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 527 of our pharmacotherapy series, which majors in anxiety disorders. The first case reads, RPR, a 49-year-old woman, complains to her physician of having trouble sleeping, feeling tired and nervous, and worrying constantly. RPR was divorced 2 years ago, and she retained custody of their 15-year-old daughter. Since her divorce, RPR has returned to work as a nurse, but she worries constantly that she will not be able to earn enough money to support herself and her daughter. She has hypertension, asthma, and seasonal allergies for which she is prescribed hydrochlorothiazide 12.5 mg per day, losartan 50 mg per day, montelukast 10 mg per day, albuterol 1 to 2 puffs every 4 to 6 hours as needed, abbreviated as PRN, wheezing and shortness of breath, and pantoprazole 40 mg per day. She also takes over-the-counter loratadine 10 mg per day and pseudoephedrine 60 mg every 4 to 6 hours as needed for allergies, naproxen 200 mg every 8 to 12 hours as needed for occasional back pain, and polyethylene glycol 17 grams daily as needed for constipation. RPR drinks 3 or 4 cups of coffee each morning and 1 or 2 glasses of wine 4 nights each week to help her calm down when she has had a stressful day. She denies any history of psychiatric illness, but states she has always been a worrier. So my first question to you reads, what factors should be considered in the clinical assessment and differential diagnosis of RPR's symptoms of anxiety? According to DSM-5 criteria for primary anxiety disorders, the symptoms should not be secondary to any medical, drug or disease causes. Let's briefly look at secondary causes of anxiety. A diagnosis of anxiety disorder attributable to a general medical condition is warranted when symptoms are believed to be the direct physiologic consequence of a medical condition. A complete physical and laboratory workup, with a thorough medical and psychiatric history, is needed to exclude reversible causes before a primary anxiety disorder diagnosis is considered. Because new onset of anxiety disorders in elderly persons is rare, this can often be attributed to some medical or substance-related cause. The presence of anxiety may complicate the medical picture and have a negative impact on the course of illness. Also, it should be noted RPR is 49 years old, and the median age for onset of menopause is 52 years. Although not a medical illness, menopausal symptoms also may include sleep disturbances and mood swings. Medical illness is associated with higher rates of anxiety compared with the general population. In some cases, the anxiety is physically induced by the medical condition, but reactional anxiety may also occur when faced with a medical illness. Successful management of the medical condition often relieves associated anxiety, but short-term anxiety treatment may be beneficial. When evaluating for possible causes of anxiety, it is also important to consider all medications a person is taking, including OTC drugs such as cough and cold preparations. A diagnosis of substance-induced anxiety disorder is warranted when anxiety symptoms occur in relation to substance intoxication or withdrawal, or when medication use causes the symptoms. Among the medications RPR is taking, pseudoephedrine might be contributing to her anxiety. Psychoactive substance abuse, withdrawal from central nervous system depressants, e.g., alcohol, barbiturates, and benzodiazepines, excessive caffeine intake, and nicotine withdrawal may go unrecognized as underlying precipitants of anxiety. RPR's current pattern of alcohol use, although not excessive, may become problematic if she uses alcohol to self-medicate her anxiety symptoms. Although anxiety symptoms are the hallmark characteristic of anxiety disorders, it is not unique to this diagnostic category. Virtually any psychiatric illness may present with these symptoms. If anxiety symptoms occur only in relation to another psychiatric disorder, then a separate anxiety disorder diagnosis is precluded. Anxiety in these cases may be alleviated with successful treatment of the primary psychiatric disorder. For example, RPR's difficulties with fatigue and sleeping may be target symptoms of either anxiety or depression, or possibly both. However, individuals with other psychiatric disorders can also have a primary anxiety disorder. In fact, comorbidity with anxiety disorders is the rule rather than the exception, particularly for depression. Concurrent anxiety and depression are associated with greater disability, poorer treatment outcomes, and higher suicide rates than either depression or anxiety alone. Anxiety in response to life stressor may be severe and functionally detrimental, but could be considered appropriate for the circumstances. Usually, this type of anxiety is self-limiting and brief, subsiding over days to weeks as the person adapts to the new situation. If the person has no history of an anxiety disorder and the symptoms last only a few months, a diagnosis of adjustment disorder with anxious mood may be appropriate. If the symptoms are severe and continue for a prolonged period, a primary anxiety disorder may be present. The initial onset of a chronic anxiety disorder often occurs during a stressful period. Short-term or intermittent therapy with anxiolytic medication or counseling can be extremely beneficial in helping persons cope during times of acute stress. In contrast, management of primary anxiety disorders usually requires more extended treatment. In summary, the factors in RPR's case warranting further investigation before a primary anxiety disorder diagnosis can be made include her medical illness, that is asthma, possible onset of menopause, her use of pseudoephedrine and caffeine, and her adjustment to the recent life changes, that is divorce, returning to work, and becoming a single mother. These factors need to be addressed and treated, if possible, before a diagnosis of an anxiety disorder can be applied and appropriately managed. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 528.